Hello and a wonderful good afternoon, everybody. I hope you can hear me. Can somebody confirm? I'm going well? Excellent. Welcome to another edition of FotoFinder Online Academy. And today we have prepared a beautiful program, okay? So stay with us the next 1.5 hours. We are going to talk about trichoscopy, about imaging, about all the tools that FotoFinder provides to make diagnostics and documentation easier in the field of hair loss and create also experience for your patients. So welcome. As you realize, I am today your host. Catherine is on an exhibition in Tallinn, in Estland, and I have the pleasure to be your host today, okay? And I'm in Barcelona, in the beautiful capital of Catalonia in Spain. And as you realize, I have here a great setup with new members of FotoFinder family that we will talk about later on. And I asked the wonderful Professor Tosti to be sharing with us her latest updates on trichoscopy. Professor Tosti is the one person that I can say inspired us, FotoFinder, inside out. Professor Tosti is actually the person that I can say she managed to basically convert the FotoFinder Medicam into a perfect device for trichoscopy by using the magnification, by improving the measurement of hair shaft, and obviously by all the great publications that she did at the level of diseases of a scalp, hair, and nail. Great books that I'm sure many of you have already read. Dr. Antonella Tosti is traveling a lot. And a couple of days ago, she told me that her flight schedule had been changed. That's why she could not be with us live, and she had to pre-record the session. I would like to invite you to watch this wonderful program that she recorded for us. After that, we can come back to the studio and answer your questions. Please share with us your questions in the chat. Meanwhile, you are watching the presentation of Professor Tosti. And after the break, after the session, we will have one guest with us, and our guest will answer your questions. Surprise guest for today. So enjoy the program of Professor Tosti, the lecture that she prepared, and we will see each other in exactly 30 minutes. Okay? Here you go.
Hello to everybody, and I'm very happy to be with you. I'm sorry I couldn't be at the right time, so I need to record this presentation, but I'm available for any possible question. You can email me, and I'm going to share my email with you at any time. So my talk is about trichoscopy, and I'm trying to give you an update on this technique, which I think is very, very, very useful and important. So the contents of my talk are here, so that I'm briefly going to explain you the development of trichoscopy and the International Trichoscopy Society, which is very important for you to join, also because it's a free society, and the most important application of this technique. I thank you very much, the FotoFinder team, who organize and invite also me to participate to this important meeting. So I developed trichoscopy many years ago. My first paper, as you can see below, was published in 2006. And after that, I first published the first edition of trichoscopy of the scalp, and then a second edition of the book that also included a trichoscopy of the nails. The third edition is in process now, and I hope will be available by the end of this year. So if you want to keep updated in this topic, you have the books to do that. And we also have the society. So this society was founded in 2017 in Mexico City. And here you see the four founders of the society, myself, Professor Lidia Rudnica, Dr. Rodrigo Pirmez, and Dr. Daniel Astigal, who is the president of the society now. I'm the secretary. And this society is a very interesting way to exchange opinion on this field. And, it's free. So you can just email me if you want to join the society, and I let you know how to do. I give you my email address, which is Antonella Tosti at hotmail.com. So very easy address. And, if you want, you can join this fantastic meeting in Cancun. You can take a picture of the code and you can register now. And this is going to be in Cancun from June 13 to June 16 at the Marriott Hotel. So now I'm going to discuss a little bit the technique with you, especially when trichoscopy is really important for treatment decision, which I think is a topic I want to discuss because that's our job to treat our patients. And here are, the topic I'm going to discuss with you. First of all, androgenetic alopecia. We all see many, many patients with androgenetic alopecia. Let's say maybe at least 50% of our consultants are on this topic. And here you make the diagnosis by looking at the thickness of the hair. And so we say hair diameter diversity, and you need more than 20% of diversity in the hair diameter to make this diagnosis. And you also can make the diagnosis looking for thin, short hair at the in the frontal scalp. So miniaturized hair are thinner, shorter, and lighter than the original hair. And you see thinner is the hair diameter diversity we just discussed. You see here many hair are thinner than the original one that you can see here. But they are also shorter, and you see these short regrowing hair that are thin and are very typical of androgenetic alopecia, and are also lighter. This is very, very evident in severe case. You see this patient had dark hair, but now his hair became much lighter. And so the hair diameter diversity is a sign of miniaturization, and the severity goes along with with the severity of androgenetic alopecia. And the question that was asked by Dr. Sinclair a few years ago is miniaturization always treatable? And the answer to this is not. So there is a point when miniaturization is not reversible anymore. And which is this point? This point is when all the hair of the follicular unit, including the primary hair, are affected. And I'm going to show you how this is very evident using trichoscopy. Here you see a follicular unit, and you see this is the primary hair. This is still terminal, but you see the secondary hair miniaturized. You can see emerging together. And you see that at dermoscopy very well, but you see here another follicular unit, and you see all the hair in this follicular unit are miniaturized. So, and when all the hair in the follicular unit are miniaturized, you see this again here, miniaturization cannot be reversed by medical treatment. And you see this very, very often on the hairline, for instance, where most follicular units are all miniaturized. This is important because it gives you an idea to the expectation you have to give it to your patient, and when you really need to tell the patient that hair transplantation is only possibility. Another example was showing follicular units mostly consisting of miniaturized hair. Let's discuss alopecia areata, and you know very well that in alopecia areata the follicular openings are preserved, and you see them here very well. and they look as yellow dots. We'll show it to you in a few minutes. But in alopecia areata, you see very typical diagnostic features. The most important one is the exclamation mark hair, and yellow dots, black dots, pigtail hair. Let's see one by one. These are the exclamation mark hair, and the exclamation mark hair are very typical because they have a broken and thick and darked tip. Okay, so the tip is pigmented and thicker than the base. And if you pluck an exclamation mark hair, you get a telogen root. Why? Because here is how it forms, okay? This is when the inflammation attacks the hair bulb and impair the keratinization of the hair shaft in the keratogenous zone. And so the follicle is able to switch to telogen, and hair is lost as a dystrophic broken hair. And this is a telogen root. It's going to grow up a little bit, becoming the exclamation mark hair. Yellow dots, you see yellow dots that correspond to infundibula filled with sebum and keratin. And as you can understand, this cannot happen in a few hours. So this is a sign of chronic alopecia areata. And you see that very typically in all individuals, in all adults with a light scalp. They may be much more difficult to see in sorry, they can be much more difficult to see in the scalp when it's pigmented. And you don't see the yellow dots in children because they don't have enough, sebum, okay? And you don't see yellow dots in elderly people, again, because the sebaceous excretion is reduced. I'm sorry, I have still like a notification on my phone. I have to switch it off. I really apologize for that. And my phone was on silent. I don't understand why it's doing that. So now we're going to discuss the black dots. The black dots are hair shafts that are fractured before scalp emergency. And you can see as black dots because the shaft is broken. They are a sign of acute alopecia areata. And then another sign that is quite often you see in children are these pigtails hair, okay? Although some authors say that they are a sign of chronic alopecia areata, I really believe they are a sign of acute alopecia areata, and you often see these pigtail hair in association with broken hair and other sign of acute disease. Other features that you see in alopecia areata but are not very typical, meaning that you can see in other conditions, are broken hair and short regrowing hair. Instead, the pseudomonolatrix or caudabilities, these are signs that are quite typical. I'm going to show you an example here, for instance, of caudability. You see this broken hair as the proximal part that is thinner. And again, flame hair, I believe you can see in alopecia areata, and are not specific of trichotillomania. You can see them in alopecia areata as well. But these are not the features that allow you to make the diagnosis. Here you see very well an example, pseudomonolatrix. This is what we call, means that the hair has a moment of a damage of the keratogenous zone. Is quite typical of intermittent disease. And here you see very well caudability. Caudability you usually see at the border of the patch, and this is something indicating the disease is worsening. So why is what is important to assess from a clinical point of view to decide how to treat the activity and of course the response to previous treatment. And so you may decide to do something different when you see in active disease with many exclamation mark hair, with many black dots. In this active disease, maybe you need steroids, you need something to stop the progression. For instance, JAK inhibitors are not the best option because they are not fast. Instead, in chronic disease, when you have the yellow dots, you can think more to JAK inhibitors in severe cases. And to assess activity, you can also do a pool test, and here you see you can assess the pool test with your dermatoscope, and here you see very well dystrophic, these are dystrophic and telogen hair, which is common in alopecia areata. Here, most of the hair are dystrophic. You have just one telogen hair. This means this is a very active disease. Again, you have to think of steroids for a patient like this. And this is with trichoscopy, again, this is a very active disease. You see many broken hair. This patient, again, needs a treatment that can stop the disease. So this, I said, is active, is not chronic, has black dots. And, you have also to avoid that this was a child, topical immunotherapy here, because, sometimes, again, is a treatment that takes time to work. And so it's not the best option in a case of acute disease. And here you see the yellow dot, and we already said that this is active or chronic. This is a sign of chronic disease because it takes time for SIBO to accumulate inside the follicular ostia. And here you have different possibility that include JAKs, okay? I want to use systemic steroids in a case like this. There are data showing that they are much less effective in this situation. So in alopecia areata, dermoscopy is very important to assess the activity and the short-term prognosis. So you have always to check the borders of the patch and also the scalp that looks apparently normal. Why? Because you can predict if this patient is going to get worse. And this is very important to the patient to know in advance. And here you see that all the scalp around the patch has exclamation mark hair. This patient is going to get worse. The patch will enlarge. You may lose all the hair. So it's better to prepare the patient, okay? And again, in this case, you see in the scalp that looks apparently normal. You have pseudomonolatrix here. You have codability. Again, this patient can get worse, okay? Of course, it's less acute than the previous one, but it's not a stable patient, a chronic patient. And then, of course, you use dermoscopy to follow up during treatment and to see the first sign of regrowth, and also to be sure there are no signs of active disease, as in this case. And with dermoscopy, you can detect a regrowth pretty soon. Lichen planopilaris. Lichen planopilaris is the most common cause of cicatricial alopecia, and I want to diagnose lichen planopilaris in a patient like this when there is still very limited damage. And, if you are able to stop the situation, this patient will have a pretty normal life. Here you see the diagnostic features. You have loss of follicular opening. You have the peripylar casts here. We're going to discuss those better. And tufting, which is another typical sign of the disease, meaning hair emerging together surrounded by a peripylar cast. So peripylar casts are these white concentric scales that surround their shaft at its emergency. They have variable thickness, and we show that the thickness, at least in front of fibrosing alopecia, but I believe that the same for lichen planopilaris, is correlated to the inflammation, to the severity of the lymphocytic infiltrate. So they are a sign of disease activity. They disappear when you apply the interface solution, and they can be seen in the scalp that apparently is not involved. So all of the above are correct. So you always have to check at the periphery of the patch to see if they are there, because this is a sign the disease is expanding. And you have also to look at the apparently non-involved scalp. So this is a patient where you have to be very aggressive with your treatment, because the disease is not limited to the area with the scarring, but also the scalp that looks normal. It's also involved. So, and even here, less severely, but you can see the scalp that looks normal. You don't see scarring here as the peripallar casts. And of course, during the follow-up, you want to see them to go away. Frontal fibrosing alopecia is a disease that is becoming more and more common. And, not only in postmenopausal women, we see now a lot of young women and men with the disease. And you know very well that they don't have just the hair problems, they lose the eyebrows, the facial papules are a typical sign of the disease, and they lose hair in the limbs. And what's typical at dermoscopy is the absence of vellus hair at the hairline. And you see peripallar casts around the remaining terminal hair, but sometimes they may be very subtle, okay? And this is what I was telling you before, that in frontal fibrosing alopecia, we were able to show that the thickness of the peripallar cast is correlated to the severity of the inflammatory infiltrate at pathology. And here this was done on dermoscopy guided biopsy. So we had the pictures, we knew the thickness of the peripallar cast, and we check the inflammatory infiltrate at pathology. Keep in mind that with dermoscopy, you can also see if these patients are applying the cosmetics into the hairline. And we know now that, cosmetics might be a part of the cause of the disease. And so here, if you see that, you have to advise your patient to not to apply cosmetics, sunscreens, anything inside the hair. And in the follow-up, again, you see when the peripallar casts go away, this is a very good sign. Discoid lupus, here you have a cicatricial alopecia and inflammatory lesion, and scaling is often a prominent feature. I've seen cases of lupus that look like scalp psoriasis, and in the scalp of color, the pigment is lost. Here you see the keratotic plaques. We can see that with the normal eye, but you can see them better at dermoscopy, and are often present also in area of chronic alopecia. But what is very important from a treatment point of view are these follicular red dots. These follicular red dots we described many years ago. You see, they look like the yellow dots, but instead of being yellow, they are red, and they correspond to follicular openings surrounded by vessels. And when you see this pattern, these patients may regrow the hair. So we usually see these red dots in about 38% of patients. And these patients need to be treated aggressively, because if you treat aggressively, they can regrow. And this is the pathological correlation. So be aggressive, regrow can be possible. And you see here an example, discoid lupus can regrow the hair. So it's maybe a different from other form of scarring alopecia. And this is another example of discoid lupus, and you see the hair regrow. So what I want you to remember, I always want to finish my talks what the most important things that you have to keep in mind to use dermoscopy at the best. And I'm going to go one by one among the 6 points. First one is always check your patients with dry dermoscopy first. So I like a contact dermatoscope without any interface solution. So you can I use a and the dermatoscope first before doing the FotoFinder and all the video dermoscopy, just to look at the patient and understand what I have to ask my staff to do, because I'm honest, often I have my stuff to do, but I tell them what to do. Because if you don't tell them what to do, you are not going to get the right diagnosis. And here you see the peripylar cast in this area, so you know that this patient should be, even with the photo finder, be evaluated with dry dermoscopy. So you look for peripylar cast, because the first thing you want to know if this is maybe a scarring or non-scarring alopecia. And peripylar cast, you see, disappear with interface solution. So if you don't look at the patient first, this patient looks like androgenetic alopecia. You send the patient to your staff, they may use immediately the interface solution and you will miss the diagnosis. So always use dry dermoscopy first, and be concerned when you see tuft of hair surrounded by peripylar casts. Another very important thing is always utilize dermoscopy to select the biopsy site. I published many years ago this dermoscopy guided biopsy. So you use your dermatoscope to select the biopsy site. And of course, the area to select depend on disease. Here you see, you think maybe lichen planopilaris, you have peripylar cast, and this may be frontal fibrosing alopecia. Again, you have peripylar cast. Discoid lupus, you either want to include the keratotic plaque or the red dots. Of course, you have to find an area that can be diagnostic for your pathologist. Keep in mind that pathologists are not magicians. Sometimes I see doctors just taking a random biopsy and sending to the pathologist. But if you don't see with your dermatoscope, with trichoscopy, any specific sign, it's very doubtful that the pathologist will see anything at pathology. So you have to give to your pathologist the right specimen. And again, inject where is needed. So don't inject blinded. Here you see there is need of injecting here. You see the peripylar cast, you inject there. Explain the disease to the patient. This is ultra important if you want your patient to be compliant, okay? Otherwise, patients have wrong expectations. So they come to see you, they sometimes don't listen to you. Most of the time, they keep what they have in mind at the beginning, at the end. And so you have to take pictures and you have to show the pictures to the patient. And if you don't have a video dermatoscope, you will do with your phone, but you have to always to take the picture. And here it's androgenetic alopecia. You show the patient the variability and explain that, of course, it will take time before those hair will get thicker, okay? Because they always expect to regrow new hair. I don't say you want to regrow new hair, but I say the most important thing is to make this hair thicker. So you have to be patient, because it will be something that won't happen in 1 week. And you can use the dermatoscope, the trichoscopy picture, to show the patient the hair that are growing back. This is a case of telogen effluvium. These patients, they fear they will be bald. They think, "Oh, I'm losing so many hair, won't have any hair tomorrow." If you show them that they are all growing back, they go out of your office much better, okay? And they will be happy to come back to see this again. And of course, in alopecia areata, show that the follicles are there. And so the fear here that the follicles are dead and the hair will never grow back. And here you show the patient the regrowing hair, and the patient is going to be, of course, much reassured by this. And in case of scarring alopecia, I always tell the patient, you see, here there are no follicles, they are gone, there are no way to grow a new one. And what we want to get rid are these, scales around the hair. So they understand what we want. And of course, you can establish, we already said that, the short-term prognosis, this is alopecia areata with a lot of, black dots, broken hair. This is going to get worse. And this is lichen planopilaris, it's very active. And so you can tell the patient that maybe it's going to get worse before getting stable. And then be aware of pitfalls, okay? Pitfalls, you have to know them and not mistake pitfalls for the trichoscopy signs, especially scalp deposits and staining. And here you have, for instance, residual of topical products. This is very common in patients applying topical minoxidil or applying topical steroids or cosmetic lotions. And you see all these are not scale, are just residues. And again here, okay, this is minoxidil. It's very typical to see on the scalp and even on the hair shaft. And this is another example, okay? So you have residues, you have to recognize the residues. Sometimes patients come to see you without shampooing because they feel that you will be able to see them better and because they want you to see that they're shedding, okay? And then you see this type of scalp. And then you may have staining. That's most commonly from dye. These are semi-permanent dye, may stain the surface of the scalp. These are permanent dye. They penetrate the follicle. And this was a patient with alopecia areata who dyed her hair. And you can see the permanent dye inside the follicle. These are not black dots. So you have to be aware of this. And this is an anthralin, stains the scalp. Again, it's not black dots. And these are permanent dyes. Sometimes they may look like the peripylar sign of androgenetic alopecia. So keep in mind that dyes stain the scalp. You have to recognize them. And patients with hair loss often apply camouflage products like fibers. So don't mistake these fibers for broken hair. And, the scalp may have pollution particles, especially in the elderly and in children. So don't confuse these with black dots. And this is again the Cancun, information. So you can take the screenshot of the information. And this is a course that I'm going to give soon. I organized this in July. So from the 12th to the 14th of July in Istanbul. And this is a very practical course. And if some of you may be interested, I will be very happy to have you there. So this is my last slide. I thank you very much for your attention. And I hope to see you in person.
Great. People, the one and only Professor Tosti and her decades of experience in the field of diagnosis of diseases of scalp and hair and nail. I really look forward to see her next edition of a book. I must be honest, her book has been the reference for us as manufacturer to continue working on our technology. I realize that you are still quite, let's say, shy with your questions. Please share your questions because we will be able to respond them as I'm going to, introduce you soon to our surprise guest for today. But before doing that, I would like to just clarify one thing. How does Dr. Tosti implement video dermoscopy for her diagnosis and documentation? If you look at the FotoFinder software, then especially the new version gives a very quick and fast access to analysis and imaging. The software Trichoscale allows you to take pictures, as you see here, at several levels of magnification. Okay, she talked about the vellus hair, about the thin hair that is below 30 micron. If you give it even a zoom, you can see that even better. You can see that thin hair in a perfect way through the this is the strength of video dermoscopy. Okay, this is the reason why video dermoscopy is so popular among those who do trichology. And of course, the software Tricho Scale DX, the new one, allows you to do this very intelligent, smart, and fast measurement of the hair, and provides you basically with the statistics at the level of vellus, terminal, and hair density. This is, in my opinion, a very important part of the story, of the configuration. So coming back, over the years, over the last decades of experience with video dermoscopy, we managed to optimize at the optical level the zoom function in order to better measure the hair shaft. So this is the precision of hair shaft measurement at FotoFinder is probably that unique point that differentiates us from the other suppliers in the market. And now, looking at this little device, I must be honest with you, the feedback we have received over years from you people out there was, if you work in a large clinic, in a large setup, and you are interested in having access to trichoscopy, you will need a portable device. And we designed this new device, which is called the Skin, in a way that it allows you to take high-resolution images. The design of the panel, as well as the quality of the optics, allows you to implement the workflow as explained by Professor Tosti in an almost perfection. That means you have the possibility to have clinical pictures, thanks to a great lens, dermoscopic pictures, and all of that in one single device that we call the Skin. I will tell you more about this when we are approaching the next part of the show. But let me introduce you to the surprise guest that I invited for today. Dr. Ahmed Sadek from Cairo, a board member of the International Dermoscopy Society, and one of those experts, passionate dermoscopists that I have known and had the pleasure to work with him since I began to work for FotoFinder, to be honest. And Dr. Sadek is today with us. I have the great honor to welcome him to be part of this session and share his experience at the level of imaging and the importance of imaging. What Dr. Tosti explained at the level of diagnosis has a lot to do with the way she does the imaging. And we not only talk about dermoscopic imaging, but also clinical imaging. I would like to ask Dr. Sadek to join the panel, please, and welcome him from the beautiful city of Cairo, the capital of Egypt. Dr. Sadek, can you hear us?
Yes, Moha. Hi, how are you doing? How's everybody doing? I'm really glad to be with you today, and always a pleasure and an honor to be among the FotoFinder Academy. We've been through the years together, Moha, yes, as you mentioned, physically, virtually. We've passed the pandemics, and here we are. Here we are talking about how we've gone through the years and transmitting the expertise to younger generations, which I believe is our message in our practice, everyday practice.
Dr. Sadek, I'm grateful that you accepted my invitation. When I was talking to Professor Tosti about this session, and I told her that one of the main challenges we have is people keep asking me how to take the imaging, especially for different types of alopecia, but not only the dermoscopic one, the clinical one, and how much patient involvement is growing over time. I mean, nowadays, the patients have really great expectations when they approach the clinic, especially patients of hair loss. That is why while I was talking to Professor Tosti, I thought, okay, who could be the perfect candidate for me to bring the audience of today's academy closer to the actual reality when it comes to imaging. And Dr. Sadek, I have to be honest. You're not only a great dermoscopist, a great dermatologist, you spend a lot of free time with photography. And that's why I thought this would be just a great benefit for our today's participants to listen to you. And I would love to ask you to share with us your presentation. The microphone will be yours, and we are very excited to hear your story about imaging and the challenges of imaging and how you are doing that. After the presentation, we will definitely talk about new tools, how that could further simplify the imaging. But I will be happy to listen to your presentation.
Thank you very much, Moha, for the invitation and the great introduction. And yes, actually, I discovered after a few years of practicing dermoscopy that my passion for dermoscopy is based on my love for photography, which has been a hobby since childhood. And thanks to you guys at FotoFinder, you are magnificent in developing machines and devices that really could do the basic stuff in a more easy way, a more simplified way, and integrating software into that helps everyone to be at ease. What I'll be talking about today, I'll be sharing the basics, how to do it with traditional devices, but also how professional hardware and software can help bring your practice to the next level, creating higher level of satisfaction for your patients. So without any further delay, I'll start sharing my screen. Okay, will you kindly confirm that everything is set? Okay, perfect. Thank you very much. Okay, so today I'll be talking about imaging trichology, my 20 years tips and tricks. Okay, so to start with, if you are a trichologist, definitely hair loss will be the commonest complaint that you have to deal with. But in my case also, if you are a general dermatologist, you will also see that hair loss is still the commonest complaint among your patients. Okay, so imaging is really crucial to deal with this big portion of patients that you deal with. This is a part of the imaging room in my private practice. And it's really important because this is how patients present to us. It's really impossible to say the exact diagnosis if it is just one diagnosis, because we often see overlapping diagnoses in trichology practice from just a photograph like this. So what's the importance of what I'm going to talk about? The importance is that we need it for objective evaluation of hair and scalp by digital imaging to define the nature and the extent of the problem being treated, in addition to facilitating the changes over time with documentation of before and after comparisons. This will help in every single scenario, but of most importance in research, teledermatology, and medical legal scenarios as well. So it comes to mind that traditional follow-up by the naked eye in the color photography is definitely not enough, because they do not provide quantitative information and are also prone to significant inter-observer variability. And also all the current non-invasive treatment modalities give this sort of gradual and subtle improvement, which is usually missed or accommodated by the patients. So we need alternatives. That's why contemporary hair and scalp imaging is divided into two parts. First one is surface imaging by standardized digital photography and subsurface imaging by trichoscopy. So let's start with the standardized digital imaging. And if everyone can know how to go for standardized digital imaging, they are sharing that via social media. They have the same light, the same angle of light, the same background, same distance, same everything to monitor the change. How cannot us professionals do it by creating our own studio at the clinic in order to be able to do this? Anybody can do it. It's really easy. You can just have the source of light that is angled at 45 degrees to the subject being photographed, in addition to having a professional camera with a plain background for sure. This is how I do it at my practice. I have this black background, and this is the tripod with the professional camera over there. This is showing you how we can do it with simple machines. And over here, you see with the video how we create the focus on the area of the patient of interest. For example, here we are changing positions for the assessment of the hair and scalp. We go for the different positions. We have central hair parting, we have proper lighting, and with the multi-focus mode, we get very good images depending on the camera that you have. So,
Dr. Sadek,
yes,
can I interrupt you for a second?
Yeah, sure.
Dr. Sadek, the way you are sharing your screen somehow is jumping between the slide and the actual overview of the whole presentation. Probably you have to change the way you share your screen with us. Because we see all the time the total number of the slides and then jumping back to the actual slide you are talking about. Probably you have to share only the screen that is basically in full presentation, full screen presentation.
That was what I was doing, but now I've switched the mode into presenter mode. Is it better now?
At the moment, we are seeing basically all the slides. We don't see the slide you actually selected. That's why I say probably you have to switch to another. Let's try another view.
Okay, sure.
Because
what about this one?
Still, I don't know how many screens you are using at the moment, but we are seeing at the moment we are seeing basically different slides in small size. So
okay, what about this way?
Just maybe try to share one more time. It might help.
Okay, just a second. Is it better now?
Yes. Now it's exactly now it's better. Probably you have to go now just to the right slide, which was your last slide, and then just go to presentation mode. I think that will be now solving the problem. So we can see now the first slide, which is 20 years.
Okay.
Okay, perfect. Now we are in the right slide. Thank you.
Okay, thank you. Thank you for notifying me. Okay, well, for the choice of the camera, some people are not very fond of photography and they think that using professional DSLR cameras will be difficult. But let me assure you that with modern cameras, there is definitely an automatic mode. But if you're not going to use this, I'll give you just 3 tips in order to get very good images, which are, first thing, if you go for the shutter speed, always use the shortest duration for the shutter speed. Here are 2 images, which we compare the duration of the shutter speed, and we find that if the shutter speed is very low, encompassing 15 seconds on the image of the right, it is really blurry because it grasps too much detail, so it's blurry. But on the left image, when it's really very fast, in a fraction of a second, it just grasps the details that are present at this very minute period of time, so no blur at all. Also, if you are adjusting the aperture, which is determining the amount of light that gets into the sensor of your camera, use a smaller aperture in order to avoid details from the background which are not needed. And definitely for sensitivity of light, go for the highest one that you can to grab the maximum amount of detail level. Okay, what are the positions for the scalp? These are my recommended set of images for standard photography of the scalp. You get one for the hairline, you get one for the back line, and 2 for the front to temporal lines. By this, you can assess the scalp in a very good manner. You can have a very good clinical photography that can be standardized in follow-up sessions. And this is the result of that. You can get acceptable images, which you can see and follow up afterwards. You can also use this for some teledermatology, like this patient, a fellow of mine has referred in order for diagnosis. These are something you can work on, though they are not still the best. In order to get the best, you have to have a dedicated workspace for imaging, as I just mentioned. Here is my clinic. Here is where I have the Medicam, where I have the facial and scalp aesthetic solution, where I have all the gadgets and add-ons for the machines, where I have the backgrounds for photography as well. Okay, and this is how the patient is positioned for the solution that is dedicated for the hair and scalp imaging. And I can take up to 6 images from different positions for the scalp. In addition to the 4 standardized ones, I can take also oblique images for the frontotemporal regions. And based on that, I can have dedicated database of the patient. All the patient's data will be recorded in my software. And I can ask also for more softwares and more assessment using the AI and other developments that I'll talk about with dermoscopy when I come to this point right away. So that was for the surface imaging. Now for the subsurface skin imaging. We have different types of dermatoscopes, including video and the digital ones, and they all utilize the same principle, which is the power of polarization of light. So cross-polarized light can penetrate deeper into the skin, giving us data about what's going on down to the level of the papillary derms. The parallel polarized light gives us impression on the surface in a very good fashion, including the visualization of the scars, of the scales, everything on the surface. And finally, the non-polarized light with fluid interface can give us impression of the superficial structures of the skin in the epidermis level. And what I recommend for you for trichoscopy, as Professor Tosti has just mentioned, that first try with dry dermoscopy or trichoscopy. I first use the polarized contact dry trichoscopy to appreciate the surface changes in addition to scales on the surface. Afterwards, I apply fluid interface and I go for polarized contact to detect any underlying pigmentary change in the skin. And finally, I finish with the polarized non-contact to be able to visualize the blood vessels of the scalp properly. By this, I can gather all the info needed for me for diagnosis. Trichoscopy can be basically utilizing a handheld dermatoscope, or watch out for the presence of the folyscope in the market. Some of these devices are promoted for being video dermatoscopes, but actually they are not. Folyscopes can only visualize the hair shafts, not the structures of the skin. So based on that, we can comment on the hair shafts, the count, the density, maybe if it has a very good software, on the mean thickness of the hair shaft diameter, but not on the skin structures. And this was a very important paper about this, which was published 8 years ago. And you can utilize in images A, B, and C the appearance of the skin of the scalp with a folyscope versus with a proper video dermatoscope on the images D, E, and F. And you can see that you can see absolutely nothing on images A, B, and C. So watch out for this very important point. So when we go for trichoscopy, in order to be able to visualize the interesting points or findings that leads to the diagnosis, we have first to assess the scalp clinically and determine what is the pattern of or the type of hair loss in the scalp. So when we clinically decide that this is a case of diffuse or patterned alopecia, we shall first go for central parting and then assess at least the vertex, the frontal region, and the occiput as control. If we're dealing with a case of marginal alopecia, we have to assess the hairlines, the site where the hairline is supposed to be present for presence of vellus hairs, and also to assess the skin for scales and peripylar casts. In cases of inherited hair shaft disorders, we also have to assess the occiput, brows, and eyelashes. And in case of acquired hair shaft disorders, we can go for the hair pull test first, and then assess the distal shaft for presence of the bulb and or fragments. And for using basic devices like this, we can have good dermoscopic images if we combine this with good clinical imaging. Like this patient, one of mine, I can get good stuff if I can really follow the rules. But still, there is something missing. I'll tell you about this in a minute, because we have also some advances that we can go for with classic photography, including using the panorama mode of the smartphones for dermoscopic imaging of the hairline, including the frontal and occipital ones, which can give better impression of what's going on. In addition to utilizing the video mode of the cameras, here you can see a patient with diffuse hair loss and inflammation, and you capture the suspect. And if you switch to the video mode, you can have a really interesting video footage like this. Okay, something is lacking. We still don't have a software for this. We don't have the patient's data that's linked to a proper software where we can have proper documentation and proper comparisons, and we cannot apply AI to this traditional imaging. So that's why we can go for more sophisticated, more modern devices, including the video dermoscopy. Here I'm using the Medicam to get clinical images first of the patient's head. And then I'm using the central parting, everything. And afterwards, I mark the areas of interest that I'm going to image with the Medicam. Afterwards, I apply the lens with the contact polarized. And then, as you see in the screen, how I apply it exactly to the site that I want to assess, and I get images. And thanks to the advanced software of the Trichoscopy DX with the AI, we can get very detailed reports about what's really going on in the scalp. And you can see over here how the AI is working, assessing every single hair that's present on the scalp, assessing the follicular units, assessing the terminal versus vellus hairs, the anagen versus telogen hairs, and also calculating the mean thickness of the hair shafts present in the assessed area. I believe this is really a very good breakthrough. Okay, just a second. Oh, my computer froze. Sorry for that.
Dr. Sadek, maybe you could just probably unshare and share again. Maybe if it comes back.
Yeah, but it's completely frozen. Okay, maybe we can answer a few questions till I solve this.
Sure. We have got quite interesting questions actually in the pipeline. Some of our participants today are asking for workshops, for trainings in Germany, elsewhere. I would say that definitely after this event, what we can do is sharing with you the dates and locations of the trichoscopy workshops that we are going to have in the next 6 months before end of the year. In Rome, as Professor Tosti already shared, in Istanbul, there is going to be one. We can share that information with you. And the other questions regarding imaging and generally regarding diagnosis, I suppose, Dr. Sadek, these questions will be answered by you when we look at the chat. So I think that will be the idea to look at those questions if you like. I don't know if do you have access to the chat of Zoom?
No, it's still frozen. I'm not able to change it so far. If you can read the question and I'll answer.
I will read the questions. Tony, maybe you can help me to get access to the questions. All right. Let me have a look. We have got, let us start with the first questions. Maybe you can scroll up so we can start with the first question that we have. Is why we said no systematic steroids in androgenetic alopecia? Why would you say no systematic steroids?
Okay, well, the thing is that there is some sort of microinflammation and prevalence of some pro-inflammatory mediators and cytokines in the perifollicular region in a considerable number of cases of androgenetic alopecia. But this is sufficient to be suppressed by local or topical steroids over a period of like 1 to 2 months, not more than this. So there is no need for the use of systemic steroids in cases of androgenetic alopecia if it's just a solo diagnosis of androgenetic alopecia and nothing more.
Perfect. Dr. Sadek, the other question is, in frontal fibrosis alopecia, how to make sure that the disease is not active anymore? That's one of the questions.
Okay, well, regarding all autoimmune disorders, it's really a challenge to make sure that there is no sort of activity right away. And that's why we do not stop treatment as long immediately after we do not see the signs of activity. We have to keep on treatment for a while with gradual tapering afterwards over a period of many months, let me say so. So back to the frontal fibrosing alopecia. We all know about the signs of the frontal fibrosing alopecia. When those signs are not there, then it's not currently active anymore, but it can regain activity in the near future. That's why we complete treatment. So what are the signs that we are looking for? We are looking for the presence of the red dots. We are looking for the presence of the peripylar casts and the perifollicular scales, which can be present over there. Also, clinical image can help, because when we go for proper clinical imaging and we notice that there is no further regression of the hairline, no further affection of the eyebrows, then at this point, when I have no evidence of progress clinically and dermoscopically, I can tell that there is no current activity. But this, again, I have to be assertive on this. This does not mean that it will not come back, because autoimmune disorders can come back if we cut off the treatment immediately.
Very good, very good. People, keep writing your questions in the chat. We have a look at them. I would like to address one issue. When we do the photography of scalp, the main feedback we have received so far all the years was the reflection. The FotoFinder camera would create too much reflection. Looking at this screen, we can have basically the same picture of the patient with two different types of light. Dr. Sadek, can you share with us your experience in photography of a scalp? I mean, do you prefer yourself a polarized, cross-polarized photography of a scalp to avoid the reflection and see better the conditions at the level of follicles, at the level of a scalp?
Yes, for sure. I prefer the cross-polarized light for assessment of the scalp. I think this gives us a better impression of what's going on deep in the scalp. But again, we have to switch between dry and wet modes, because with the dry mode, we can see better what's going on the surface. Also, with the usual light, you cannot see the details of the scales. You cannot appreciate the color, cannot appreciate the roughness or the pattern of distribution as we do with polarized light.
We at FotoFinder decided to expand the possibilities and the light options for, in particular, for photography of face and scalp. If you look at the images that I've been sharing with basically cross-polarized images and light images, those images were basically taken with this device. So the device we integrated and developed for this kind of photography is called MISMA. It is a FotoFinder innovation that allows you to be very flexible when it comes to angle and to distance and photography of the entire body parts. I mean, it's not just dedicated to face. It's obviously also allowing you to have the perfect flexibility in order to take images of of different angles of skull. And obviously, thanks to the application, as already explained by Dr. Sadek in his presentation, thanks to the application, we are able to create overlaps and guarantee very, very good and standardized follow-ups. So this device is designed in a way that you would be able to carry it from room to room. You do not need to be dependent on a room of photography. We would provide you with standardized background colors that you would place in every room of the clinic. That's what we recommend. And this standardization of the background allows you, in combination with the flexibility of MISMA, and obviously the fact that you can switch between lights. Probably, Dr. Sadek, you have got now another device. Okay, perfect. So because you have to probably mute your microphone so that we do not have an echo here. Anyway, what I was trying to say is the technology, meanwhile, allows us to have the full flexibility when it comes to photography of clinical images with the MISMA. And in addition, we designed the skin as a device that provides both clinical and dermoscopic pictures, again, with high resolution and different types of magnification. I would like to ask my colleague to share with us a video that I prepared for you to highlight the workflow with the new product that we designed with the skin for hair documentation. Hani, would you please share with us the video and I will comment it. So looking at this device, you realize that it is possible to remove the lens and take a very well standardized image of the skull, as I did. So you have got high resolution, good quality of image, and once you have got your clinical image, you are able to connect your lens back to the skin and work with several magnifications. Look at that. I'm starting with 15x. So this is a 15x magnification. I go to 20 and 40. So all of this is happening in a live image, people. And that's, in my opinion, the exact advantage of it. So yeah, that you can have a standardized magnification. Going back to Dr. Tosti's presentation, it's so good to have magnification standardized, polarized, non-polarized. You can switch between the two lights. And all of that in a full flexibility, integrated in the device we call skin. To summarize, we see that based on type of alopecia, it's helping you a lot if you have the possibility to work with different magnifications. Once you take the picture, once you have taken your clinical picture and your dermoscopic, you are able to go and save them together as one session. As you see here, with this patient, I have taken clinical picture, I have taken dermoscopic picture, and now I am able to save them. And if I like, I can add a patient or I can dedicate those images to an existing patient. It's very simple to write down the name of the patient and eventually going and saving these pictures, clinical and dermoscopic, within a patient file and having access to those pictures also through the cloud platform. So to summarize, we realize that at the clinical level in daily practice, you not only need a good and flexible hardware, a hardware that allows you to move from room to room and have the full flexibility of access to both clinical pictures and dermoscopic pictures, but at the same time, you wish to have access to your images through every desktop. Sometimes when you are working between several clinics, it's good that you have access to your images no matter where you are. And this is the new approach. This is what we say, a cloud platform of software that allows you to have encrypted and saved images saved in that platform, giving you access in multiple locations and obviously maximize your flexibility and accessibility to the patient data and images. So this is in the core message of FotoFinder. That means we are going toward the next dimension, and the next dimension means more and more flexibility for your clinics, more and more access to intelligent technology in order to maximize your time efficiency. I think listening to Dr. Sadek's presentation, to Professor Tosti's presentation, you realize the diagnosis as well as the documentation and follow-up can be a nightmare if you have no tools that help you to standardize. Otherwise, you lose too much time. And this is exactly our duty, our motivation to develop tools in order to solve that problem for you. Okay? And for that, we need good focus, good light, and obviously the harmony between software and hardware. Dr. Sadek, you have been working now with this technology all these years. I suppose comparing it with how it was before when you did it manually and not software driven, I think time efficiency plays a big role, right?
Definitely, Moha, definitely. And also this answers one of the questions that's present on the Q&A on how the MISMA can help us for standardized photography. Well, actually, the thing is that when you have more tools, you can get more data, you can get more info, you can give the best for your patient. And thanks to the development of the cross-polarized light in good quality, because not all the devices provide the same quality of filters for cross-polarization of light. This is something that you have to check for yourself. What I do when I ever introduce to a new device, I have one cherry angioma on my forearm and one nevus on the back of my hand, and I check those, utilizing the different lights that are provided by the device. So we have cross-polarized light, we have parallel polarized light, and we have non-polarized light in addition to UV. What else do you need? This gives you the impression of all the details that you need of the skin and scalp and hair as well. So what I recommend is that we can go for the parallel polarized light to see any surface irregularities of the skin or the hair shaft from the outside. And we can go for the cross-polarized light to see the vascular structures and the pigment that is present down there. Then we switch to the UV, and remember to tell the patients to close their eyes with the UV in order not to hurt them, because this will highlight more the presence of the pigment and will let you appreciate better the depth of the pigment that is deposited in the skin. And after all, the non-polarized light with fluid interface will help you to detect pathologies that are present in the superficial layer of the epidermis. By this, you can collect many data about the skin in a non-invasive fashion. So what about standardization? Well, the MISMA has the same camera, has the same light output. What you lack is the background and the distance and the lighting of the room. So what I recommend for you is that the MISMA has its own light. You do not need specific lighting for photography in your room. So just have standard light in the ceiling of your room, and that's it. So this is number one. Number two is that you get a dark background that is non-reflectant and use it behind all your patients. And then after all, just get a stand to have the MISMA at the same certain distance from the patient at each time you use that. And I've seen it with the FotoFinder. They have created this very nice dark booth. I'm not sure if you can deliver it to physicians at their practice or not, or this is just for the show.
Dr. Sadek, you can read my mind. We created a docking station for MISMA that is basically in a square size, as you know it from exhibitions, and that will be available for sales within the next 4 to 6 weeks. So as you can imagine, we want to preserve the flexibility of MISMA. So whenever you want to do, basically, you want to simulate dark room, you would get that docking station from us, which allows you to put the face of the patient within a dark environment, standard, even maximizing the standardization. You can dock in the MISMA, take the picture, and if you want to do body photography periphery, or if you want to take pictures of the arms, a scalp, you have still the possibility to remove the MISMA from the docking and place the patient in front of a dark background, as you mentioned, and take your body photography. I think one of the reasons for success of this device is that it's flexible and at the same time coming with an iPad already installed in it, which allows you to easier communicate with the patient. In my opinion, the moment you take the picture, you see what you get. Whereas if you have a device that requires processing time, you don't know if the picture you took is actually relevant, is it good quality or not. Here you see immediately. If the focus is not good, if the distance is not good, you just repeat it. And thanks to the ghost function, you can just create an overlap and basically do a perfect follow-up. So the software-driven guided photography is now, I would say, perfectionized thanks to the possibilities of light that we have now. We used to miss this device because the other devices of FotoFinder did not give you all the light possibilities. This is now basically the solution to a lot of challenges we had in the past. We can adjust the light intensity, we can adjust the type of light, as you mentioned, and with this, there is no wish that we cannot remain unfulfilled.
Yes, I totally agree for that.
Perfect. Perfect. Dr. Sadek, maybe one last question that would be addressed to the skin. When you do trichoscopy, when you do trichoscopy of the hairline, how do you make sure that you have the maximized field of view dedicated to the hairline in order to have the best results when it comes to hair count and the hair density? What is the magnification that you use with your Medicam, and how is the workflow in your daily practice?
Well, okay, I first start with clinical imaging for sure, because this is the first thing that we have to do. And this is how we localize exactly the where we have put our dermatoscope and where we are counting the hair and assessing the scalp in order to make future comparisons really accurate. The standard magnification that I use for video dermoscopy is 20x magnification, which I usually use for general assessment of the scalp and the calculation of the hair shaft diameter. But when I try to visualize vellus hair more or go to hair shaft disorders, I use higher magnifications of the Medicam that we have up to 70x optical zoom and up to 140x digital zoom. This gives me a higher potentiality for visualizing changes of the hair shaft as well.
Dr. Sadek, I ask this question because very often in presentations, in exhibitions, I realize that our users with the Medicam, they might not use the image. They might use the Medicam in a vertical or in a horizontal way, and based on that, they obviously have an impact on the fact that they might not get as many follicular units as possible on inside the image. So with the skin, what we did is, in fact, we solved this problem. The size of a skin allows you to automatically go with the hairline. You understand? As the screen is vertical, you would automatically have the maximum number of hair units basically covered, and at the same time, the skin has got a larger field of view compared to Medicam. I mean, you have got all the advantages. You have got the magnification, but your standard magnification is allowing you to have a larger field of view. Obviously, together with the ergonomy of the device, as it allows you to basically take the picture in a very ergonomic way. As you see, the screen is in front of you. You can much better position the device on the patient's scalp, switch between polarized and non-polarized light. You have the possibility to almost perfectionize the photography of the scalp and also the localization. So this is there's this feedback from trichoscopists among the dermatologists I work with was very crucial for us when we were in dealing with the design of the skin as a product. And I believe again, the next month and until end of the year, we have got several big events coming up. The World Trichoscopy Congress in Cancun. We are going to have the Barcelona Hair event in September. We have got with Michela Starace and Bianca Maria Firacini a workshop in Rome, and all of that will give me a bit more direct feedback in order to further adjust this. You can imagine the tools that we have been looking at, analyzing the hair with using AI, all of that will be possible also with this tool. Step by step, it will be integrated. And our goal remains to save your time. All of it, if we summarize, whatever FotoFinder does, even though we are so passionate about imaging, we are so passionate about optics, software, AI, but eventually, if you bring it down to the point, it's designed to save your time. Really, I see, Dr. Sadek, how many days during the week you are working, how many patients you have, and all the other dermatologists and friends that are working with our tools. I am very happy about what I do in this job when I see that it can really give you some more time with the patient, save you the time in dealing with and preparing the device. If the devices become more intelligent, they will exactly dedicate the extra time to you in order to spend this time with the patient. The patient experience, in my opinion, is more and more important because patients come biased to the clinics due to social media, due to their access to Google generally. They Google a problem and they have large expectations. Therefore, combining intelligence of machine and time of the physician with the patient is, in my opinion, one of the most crucial issues in the future. How do you see that?
Well, that's really very important. You know, I haven't used the skin before. Last time we met, it was not out to the market yet. But I'm really impressed that you are using really where it's some sort of like telepathy. You see, I've shown the panoramic assessment of the scalp, and I didn't know that it does this. That's why I have mentioned in the beginning that you're really bringing our ideas and our experience to life. You're really investing time with very big passion in order to give us what we really need based on what we are going on daily basis. So with this device, I definitely have one, and with integration with the AI, it will be just like the absolute solution, which is contemporary and really very nice to have on your practice.
Dr. Sadek, again, I think any manufacturer can be successful by listening very carefully to the feedback of the customers and users. And I must be honest with you, looking at FotoFinders today, I mean, at our devices, the device here next to me is one of the most, let's say, sold units that we have in Europe and elsewhere, with a video dermoscopy camera that made us famous worldwide. But you know, if I look at Asian countries, African countries, a lot of countries that are more and more now entering the world of dermoscopy, thanks to the investigations and scientific papers that are being published at the level of inflammatory issues, at the level of phototype of a skin 4, 5, 6. The dermoscopy is going into a new dimension thanks to more and more experts and physicians having access to it. And you have heard that FotoFinder and DermLite are now fusioned. And this was, in my opinion, one of the biggest contributions and to my personal motivation doing this job. DermLites are affordable, okay, and are very simple to use. And thanks to the DermLites possibility of providing polarized and non-polarized light with the DL100, thousands of dermatologists worldwide became interested in this field of dermoscopy, both for pigmented lesions, non-pigmented lesions, as well as for trichoscopy, onychoscopy. This is the way to go. I can tell you, this is our philosophy, our mission, to make even more intelligent tools like a skin affordable and accessible for a bigger number of physicians. And I can tell you, from economic point of view, this little piece of hardware is obviously a lot easier to export to new markets like Indonesia, Philippines, India, African countries compared to this big machine. But it provides a big part of the value, okay? And definitely will help to train the eye. And therefore, I think inside FotoFinder and Dermlight, we are so enthusiastic that we developed the products in the right direction, keeping them intelligent, maximizing the image quality, both clinical and dermoscopic, and making them accessible. I think this is the only right approach of a manufacturer like us who are dealing with an audience at a global level. And Dr. Sadek, I'm looking forward to share with you our thoughts on dermoscopy of phototype of a skin 4, 5, and 6. We are not experienced in that yet. And I'm sure in Egypt, in many of your colleagues in Africa, I have seen a latest paper that you published on that with African colleagues. Maybe you can mention that and how people could read that paper.
Well, yes, it's been published in the official journal of the International Dermatology Society, which is the journal of DPC, Dermatology Practical and Conceptual, and it's about the current trends in the use of dermoscopy in Africa. And I assure you, it's on the rise. There is difference definitely between fair and dark skin phototypes in their behavior towards the incident light, but this is being understood, this is being analyzed, and we are getting to get used to get much data from the darker skin as well as with the fair skin phototypes, and with the introduction of the affordable new devices that are to trust and also not that big to be shipped and carried on and used on everyday basis. I think this will be a breakthrough for new markets in order to introduce this trustable technology to them.
Thank you. Again, without the help of International Dermoscopy Society, their feedback and their time that they invest in research, we as manufacturer would not have been able to focus our resources on the development of tools that remain practical. So the tools that are not practical, they will not survive in the market. That's how it is. And I think the time you invest, I love to read the papers you publish because it inspires me, it inspires also the entire team around Dermlight and FotoFinder, and that is the way to go. People, within the next hours, you will receive links for those of you who have not been able to be live with us in Asia, in Latin America. They can watch this session in a recorded way. And all the others who have interest to receive more information about the new technologies at the level of hair count AI for hair measurement, at the level of MISMA for clinical photography or skin, you will be able to ask for information, validations, and also quotations via the emails that will be shared with you within the next hours, okay? So thank you again, thank you very much, Dr. Sadek, for being live with us from Cairo. And Professor Tosti sent me a message giving you her best regards. And I hope to see you soon in person, live. Wish you all the best. Dr. Sadek, the last words are yours.
Thank you very much. I was really glad to be with you here today. Looking always for the best. And don't forget about Buenos Aires in October, the World Congress of Dermoscopy as well.
Definitely, people, World Congress of Dermoscopy, the first one in life since 2018. The last one was 6 years ago. And this year, by 17 to 19 of October, we will be in Buenos Aires, the global meeting of International Dermoscopy Society. So if you want to get yourself familiar with the latest developments and scientific papers at the level of dermoscopy, trichoscopy, onychoscopy, if you want to see a lot of colleagues sharing the same passion, book a ticket, come to Buenos Aires, and I tell you, during springtime, which is October in Buenos Aires, you will fall in love with Argentina as a country. That's what we can guarantee. So hope to see you all, hopefully also in Argentina. Wish you a wonderful Friday evening. Or Friday morning, based on those who are from Latin America with us today, and hope to have you soon with us in person on one of the shows or in Buenos Aires. Wish you a lovely weekend. Thank you very much for staying with us, and see you soon on 6th of June with an edition of FotoFinder and Dermlight Academy. So it's gonna be celebration of the wedding, Dr. Sadek. I hope you will join us.
Definitely, it would be my pleasure.
Wonderful. People, thank you very much for being with us. Wish you all the best and see you soon.